and thank you all for joining us tonight. We're very pleased to be able to welcome you again in joining this event. And today is, as you know, the 7th day of the Congress. And so we'll start with the first session on practical aspects of reversal of direct oral anticoagulants. This session will kindly be presented by our distinguished speaker, Dr. Mark Crowther, who is currently the chair of the Department of Medicine at McMaster University and holds the Leo Pharma Chair in Thromboembolism Research at McMaster University. Dr. Crowther's research interest includes exploring ways of improving the way that our current anticoagulant drugs are being best delivered for the safest, with the safest outcome for our patients. So, starting with Professor Crowther on the practical aspects of reversal of oral DOACs.
Or afternoon, everyone, and welcome to my presentation. I'm Mark Crowther. I'm the chair of the Department of Medicine at McMaster University, and I'm going to talk today about the 2021 approach to anticoagulant reversal. I'm using my own slides plus slides from a variety of other people, most notably Dr. Adam Suker, who's a professor at the University of Pennsylvania and a good friend of mine. I have a number of disclosures. I won't go through these in detail other than to say that over the years, I've done work for all of the companies that make anticoagulants and all of the companies that make reversal agents. I also hold an endowed chair at McMaster University, which is funded to allow me to continue to do my research activities. With respect to reversal, the direct oral anticoagulants have almost completely replaced warfarin except for some specific unusual circumstances. But warfarin use remains highly prevalent in what I call the chronic user population, people who've been on warfarin for years and have no intention of switching. The direct oral anticoagulants were introduced in the absence of specific reversal agents, and for the most part, such agents are simply not required. So the question is warfarin dead yet? And this is relevant to reversal because the most common kind of reversal that we do in our hospital at McMaster University is not DOAC reversal, it's actually warfarin reversal. In fact, warfarin reversal probably outnumbers DOAC reversal by at least 10 to 1. The short answer about whether warfarin is dead yet is no. Warfarin remains the most commonly prescribed anticoagulant because there are many patients out there who've been taking it for years. It also is the least expensive of the agents, and it is going to be the only agent that's going to be preferred for a number of clinical settings, including mechanical heart valves, patients with renal insufficiency, patients with more significant forms of antiphospholipid antibody syndrome, and also because of physician inertia. That is, physicians are going to continue to prescribe the drugs they're most familiar with, which in this case is going to be warfarin. In terms of reversing warfarin, because any reversal talk wouldn't be complete without covering this off, the most important drug, in fact, the only drug that should be considered for the reversal of PCC is, for the reversal of warfarin, is prothrombin complex concentrate. Remember that warfarin has two highly effective antidotes, prothrombin complex concentrate and vitamin K. Both should be administered together in patients with major bleeding in the setting of warfarin anticoagulation. Prothrombin complex concentrate is rapidly acting virally inactivated, small volumes of plasma, rapid infusion, and no cross match is required. And vitamin K, when given intravenously, is inexpensive, widely available, but does not act in any way in a quick fashion. So when reversing warfarin, guideline recommendations from all major peer organizations, such as the American College of Cardiology and the American Society of Hematology, recommend the use of PCCs over fresh frozen plasma. And there are other agencies that also recommend this. The National Advisory Committee in Canada, which guides the use of blood products, has also come out with a recommendation to use prothrombin complex concentrates for warfarin reversal. And they say that the prothrombin complex concentrates are indicated for rapid reversal of warfarin therapy or vitamin K deficiency in patients exhibiting major bleeding manifestations, and for rapid reversal of warfarin therapy or vitamin K deficiency in patients requiring urgent surgical procedures. So there should be no complexity to how major bleeding in a warfarinized patient is treated, irrespective of the INR. It should be with the administration of PCC plus vitamin K. There's nothing more to say about warfarin reversal, I don't think. Remember that if a patient presents with a high INR without bleeding, you don't need to reverse them. You can withhold doses of warfarin and allow the INR to coast down before restarting. If the patient is perceived to be at moderate risk of bleeding, then you might consider giving a low dose of vitamin K to reduce the risk of the INR remaining persistently elevated. And if the person is perceived to be at high risk of bleeding or is active bleeding with warfarin, give them PCC and vitamin K. So now let's move on to the direct oral anticoagulants, which is the focus of the talk. Mrs. Smith is a 72-year-old woman with atrial fibrillation and a CHADS-2 score of 4, which puts her at high risk. Her primary care physician starts her on dabigatran at a dose of 150 milligrams twice daily for stroke prevention in the setting of her high-risk atrial fibrillation, and fails to notice that she has a creatinine clearance of 23 mils per minute. That is obviously a contraindication to the use of dabigatran. Renal insufficiency and dabigatran just don't mix. Dabigatran is very dependent on the kidneys for its clearance. 2 weeks later, she presents with major hematemesis to the emergency department, to no one's surprise. One of the questions we get asked when we're approaching a person who may need reversal is, how do you tell if they have a direct oral anticoagulant on board? And for dabigatran, it's actually relatively straightforward. Dabigatran, when it's present in significant amounts, will increase the PTT. So this patient we're talking about right now, we would expect her to have an elevated PTT. In addition, even small amounts of dabigatran will increase the thrombin clotting time, the eccrine clotting time, and a specific assay for dabigatran, which is known as the hemoclot assay. You can do specific levels of dabigatran using the hemoclot assay, but those are only going to be available in selected centers and usually only during office hours. If the patient's taking rivaroxaban, apixaban, or edoxaban, things are a little bit more complicated. For rivaroxaban, if the INR and PTT are usually normal, or the PTT is normal and the INR is slightly prolonged, you cannot use the INR for monitoring rivaroxaban. So if a patient shows up in the emergency department and the question is, do they have rivaroxaban on board, and their INR is 1.8 and they have no reason to have an INR of 1.8, you can safely assume that they've got rivaroxaban on board. Apixaban does not reliably prolong any clotting test. So you could take a large dose of apixaban, and 3 hours later, when you're at peak pharmacokinetic effect, you would not expect the person to have any significant prolongation of their INR. There are specific assays for both rivaroxaban and apixaban that are very sensitive, and there's a couple of different technologies for this, but again, these are only going to be available in selected laboratories and only going to be available during usual office hours in the vast majority of cases. Edoxaban behaves somewhat like rivaroxaban, so it should prolong the standard clotting test when it's present in high amounts. So with respect to this patient, remember, older lady, dabigatran, severe renal insufficiency. The question is, what lab test would be most helpful to determine if she has dabigatran on board? The INR, the PTT, thrombin clotting time, ROTEM, or the platelet count? There's really 2 answers to this. The TCT is the most sensitive. The problem with the TCT is that even if you have a small amount of dabigatran, it's going to become incoagulable. So if the TCT is abnormal, that means she has dabigatran on board. The PTT is actually a little bit quantitative. So the higher the PTT, the more dabigatran on board. And so for this one, I've said the answer is the PTT. Assuming that testing returns promptly, the PTT is found to be 135 seconds with a normal time of less than 35 seconds. The question is, if it's available, should she receive idarucizumab, yes or no? So this woman presents with a major bleed in the setting of a direct oral anticoagulant. What is her risk of death? Risk of death is really high, and I'll show you some evidence to this effect in a minute. And so she should receive idarucizumab if you have it available. Another question we get asked all the time is, once you've infused the idarucizumab, how quickly will the anticoagulant effect of dabigatran be eliminated? Less than a minute, less than 5 minutes, less than 30 minutes, less than 1 hour, or it will not be eliminated? And the answer is immediate. The drug immediately is bound to the idarucizumab and cleared from the circulation, so it provides immediate reversal. Direct oral anticoagulants and the other anticoagulants are high-risk drugs. And so this is data published by Dr. Nadine Shahab, looking at U.S. emergency department visits for outpatient adverse events in 2013 and 2014. And this looked at the drugs that were most likely to cause emergency department visits. And you can see that in this list, of the top 5 drugs, 4 were antithrombotic agents. Warfarin dominated, followed by insulin, then clopidogrel, aspirin, and rivaroxaban. And if you repeated this now in 2021, you would probably find that apixaban is on this list. So the anticoagulants are high-risk drugs. They have a high rate of complications, and they frequently cause complications such as bleeding, which require hospital visits and hospital admissions. So whenever a person is on an anticoagulant, remember that they are high-risk drugs, use them in compliance with guidelines, and when bleeding occurs, it needs to be managed aggressively to prevent the patients from having an adverse outcome. A question that we get asked all the time about, particularly rivaroxaban and apixaban, is do we need a reversal agent at all? These drugs are highly safe. Bleeding is uncommon in patients anticoagulated with the direct oral anticoagulants. Bleeding is not actually caused by the drug, it's caused by compromised vascular integrity. That is, there is a hole in the blood vessel which is bleeding. The drug itself does not cause the hole in the blood vessel. Bleeding risk factors can be identified and mitigated. You can reduce the risk of the person suffering bleeding. Reversal strategies are ancillary to fixing the lesion. What I mean by that is that the primary way you deal with bleeding is to have an interventionalist go and identify where the bleeding is coming from and fix that. All bleeding stops. You can be confident that bleeding is going to stop. You just want to make sure that it stops physiologically or as a result of your therapies, not because the patient has died. So all of these things argue that you don't need a reversal agent because most bleeding is going to stop, and most bleeding is fixable with interventionalists. However, there are some reasons to have a direct antidote. One is that the simple availability of an antidote is going to increase physician comfort with using the drugs and increase their appropriate utilization. And a patient who's actively bleeding, reversal agents may reduce the severity of the drug, and reversal agents may reduce the likelihood of bleeding if used prior to selected interventional procedures. So just talking about that for a second, because a very common cause of bleeding is perioperative bleeding. In fact, at my hospital, I was on call last weekend and we had a patient who went to the operating room and the surgeons had failed to notice the patient was on warfarin and immediately prior to the surgery had an INR of 2.2. Obviously, that's a completely avoidable cause of bleeding, but it is an important cause of bleeding, inadvertent procedures or procedures done because they were emergent in a patient who's anticoagulated. For elective surgery, careful management of anticoagulants to minimize anticoagulation risk at the time of surgery, while also ensuring the lowest possible risk of thrombosis, will mitigate the risk of bleeding and mitigate the need for reversal agents. And there's a whole separate talk to be had on bridging strategies. And for urgent and emergent surgery, you need to have meticulous attention to surgical technique and consideration of the use of reversal agents. Accurate and timely laboratory testing is also critical to prevention and management of bleeding because it provides, in some cases, an estimate of the degree to which anticoagulant is contributing to bleeding, and will also guide the use of reversal agents if testing is available in real time. And I know, for example, at King Faisal in Riyadh, you have access to really excellent laboratory testing, but I know that in many other centers in Canada and in Saudi Arabia, particularly quantitative level drugs are just simply not going to be available in a timely fashion. The easiest way to treat a bleed is to avoid having it, and there's a wide variety of excellent, very clear tools available to provide advice on how to optimally use antithrombotic agents in order to reduce the risk of bleeding. And the most common reason why avoidable bleeding occurs is physicians add antithrombotics one on top of the other inappropriately without actually considering why they're using multiple antithrombotics. And there's a wide variety of different evidence-based and free guideline tools on how you should use antithrombotics. I've presented two here. The Canadian Cardiovascular Society has a large number of guidance documents, as does other agencies such as the American Society of Hematology and the Thrombosis Canada. And these guidelines will help you to practice in compliance with the recommendations, and by reducing and rationalizing your use of anticoagulants will minimize the risk of you causing avoidable bleeding. A good example of this is a study published recently by Dr. Renato Lopes, who works at both Duke and in Sao Paulo, Brazil, which was looking at the optimal antithrombotic therapy after acute coronary syndromes or PCI. And so this is the question of if a person has atrial fibrillation and also gets a stent put in, should they be put on triple therapy? And we now have clear data to inform us about how these people should be treated. If you have a patient who has atrial fibrillation and has an acute coronary syndrome or PCI, the combination of apixaban plus clopidogrel is safer and more effective than any other combination involving warfarin or triple therapy. Apixaban plus clopidogrel causes similar or lower risks of bleeding and similar or better efficacy than anything else. And so if you ever see a patient who's on warfarin and aspirin and clopidogrel in 2021, that is placing the patient at unnecessary risk of bleeding, and you should use the results of the Augustus study plus others to inform your practice and to get the person off the aspirin and put them on a more rational treatment strategy. Not only will this result in them having a better clinical outcome in terms of their coronary syndrome, but it will also reduce their risk of otherwise avoidable bleeding and reduce your need to reverse them. Implementation of these evidence-based guidelines will dramatically reduce warfarin-associated bleeds and reduce the need for reversal strategies. And the easiest way to treat a bleed is to not have it in the first place. What is the consequences of major bleeding? Well, these are significant and severe. This is a paper published by a colleague of mine, Dr. Chayada Saksofa, who is from Thailand. It was published in Blood in 2014. And what Chatri did is he took all of the studies that led to licensure of the direct oral anticoagulants. At that time, there were 102,000 patients enrolled in these studies. And what Chatri was able to show was that when you compared therapeutic dose direct oral anticoagulants with therapeutic dose warfarin, major bleeding was reduced by about 28%. Fatal bleeding was reduced by almost 50%. Intracranial bleeding was reduced by almost 60%. The only bleeding that wasn't significantly changed was GI bleeding. And so using a direct oral anticoagulant when compared to warfarin resulted in really important reductions in intracranial and other forms of bleeding. And so another way to reduce bleeding is to switch patients who are able to be switched from warfarin to a direct oral anticoagulant. By doing that, you will reduce the need to reverse people because the rate of bleeding will be reduced. So the question is, if you have a patient who's on a direct oral anticoagulant and is actively bleeding, when do you actually intervene to reverse that patient? And there is some evidence to help us to understand when this should happen. You should ask yourself, in my opinion, 3 questions. The first question is the drug present in significant quantities? And remember that if the patient presents to the emergency department in the study that we did that led to the licensure of Vexinet, almost 25% of patients didn't have important amounts of the drug present. So just because the patient comes in with a pill bottle containing rivaroxaban, they may not have it on board. It's really important to try to determine when they took their last dose. If the person took their last dose of rivaroxaban 36 hours ago, then it's very unlikely that they're going to have drug present. The second question is, does the agent need to be reversed? Clinically important or clinically impressive bleeding doesn't always require reversal. So epistaxis, for example, may look spectacular, but it does not need to be reversed in most cases. Remember that whenever you reverse a person, you're increasing the risk of otherwise avoidable thrombosis. So if bleeding is minor or easily delayed, or if it's a surgical procedure and it can be delayed, just wait. And you will find that the anticoagulant effect goes away and the bleeding may actually be mitigated by that. In fact, around the world where Vexinet is only available in very limited circumstances, almost all DOAC bleeds are currently managed without a reversal agent. If you've decided the drug is present, that the person should be reversed, then the third question is, how do you do it? Well, there are principles of bleeding management, and there's a wide variety of guidelines that speak to this. Transfuse patients as required, work with your interventional radiology, gastroenterology, or surgical colleagues. Consider the administration of DDAVP, tranexamic acid, or epsilon aminocaproic acid. If the person is on a 10A inhibitor and you have access to Vexinet, then you should consider using it. In Canada, we don't have Vexinet, so in the setting of life-threatening bleeding, we would use PCCs. If in the setting of life-threatening bleeding with dabigatran, consider idarucizumab. In Canada, we do have idarucizumab and we would use it. And as I presented at the start, for warfarin, use the combination of PCC plus vitamin K. Are there specific implementation strategies that would allow you to mitigate the effects of bleeding? Absolutely. This is a paper published by Adam Suker a couple of years ago. And if you're thinking about how to set up a reversal strategy, I would suggest that you have a look at it. It talks very comprehensively about how to set up a reversal strategy and how to implement it. The most effective way to ensure safe and effective prevention and treatment of bleeding is rigorously adhered to institutional policies. Clinicians who encounter perioperative management and reversal infrequently just can't know how to do it. And so your institutional policies are what are going to lead to effective reversal strategies. If we talk about evidence briefly, there are never going to be large randomized controlled trials of reversal strategies for bleeding because the studies are extraordinarily difficult to do. And we won't get into that today, but you have to trust me on this. Idarucizumab, I'm not going to go into this in great detail. I think you've probably all seen these slides before. Charles Pollock published this paper in 2017, which looked at the efficacy of dabigatran. It's a monoclonal antibody fragment, which comes in pre-diluted vials. It's very easy to use, and it immediately reverses the anticoagulant effect of dabigatran. This is data from the study which Dr. Pollock published. If you have a patient who gets dabigatran and is given a placebo infusion, This happens to their dabigatran level, and as you give increasing doses of idarucizumab, their dabigatran is immediately and completely neutralized for the entire period of the study. So it's an instantaneous and complete reversal agent. In the study, there were two groups of patients, patients who were actively bleeding, about 300, and I won't present the results in great detail other than to say that the patients did really very well, and hemostasis was achieved in the large majority of patients. And a second group of patients, about 200, who needed urgent or emergent surgery, who received the drug. And again, I won't go into detail other than to say that the patients did really well. The 203 group A patients who could be evaluable for bleeding outcomes, 2/3 had confirmed stop of bleeding, and the median stop of bleeding was 2.5 hours. And in the group B patients, hemostasis was assessed as normal in 93% of patients. As I mentioned earlier, remember that whenever you reverse an antithrombotic agent, you're going to increase the rate of venous thromboembolism because these patients have thromboembolic predispositions, which is why they're anticoagulated in the first case. And so in this study, 31 of 494 patients had 35 thrombotic events by 90 days. And this is not surprising. This is not because the idarucizumab causes clots. This is because you took patients who were at risk of thrombotic events and took them off their anticoagulants. And as a result, they didn't have the benefit of the anticoagulants and went on to have clotting events. And Vexinet is a modified factor 10A. It's had some chemical magic performed to it, which does two things. It continues to be able to bind to the 10A inhibitors with high avidity. The active site has been changed so that it no longer participates in coagulation. The GLA domain has been removed to prevent an anticoagulant effect, so it can't bind to phospholipid surfaces. And as a result of that, it doesn't interact with coagulation. It has no known interaction with any coagulation factors except tissue factor pathway inhibitor, and it does not cause neutralizing antibodies. Deb Siegel published this paper a couple of years ago where she looked at the effect in patients who are dosed steady state healthy volunteers. And I won't go through this in detail. If you give a bolus of Vexinet, you immediately reverse the 10A effect, and then you have a slow return because the Vexinet has a short half-life. If you give a bolus plus an infusion, you maintain low levels for the entire duration of the infusion for both rivaroxaban and apixaban. And there's two different dosing regimens which are recommended for the use of this agent. This is a licensure study, a total of 325 patients who had acute major bleeding, of which 225 were intracranial, and they were evaluated for both their anti-10A level as well as clinical hemostasis. And suffice it to say that a very high proportion of patients had excellent hemostasis, and the large majority of patients had complete reversal of the anti-10A effect. Just remember, once the infusion stopped, the 10A effect will come back. And then Vexinet's been available in the United States now for a couple of years, and the question is, how has it gone? There's a whole series of observational studies published. This is one an experience at a major non-academic center in the United States. 13 patients with intracranial hemorrhage, 11 of whom had follow-up imaging, and stability in the bleed was observed to 90%. 3 patients received it prior to surgical procedures, which is an off-label indication. None had unexpected bleeding. 9 patients received it for reversal of extracranial bleeding, of which 4 were gastrointestinal. No thrombotic events were observed. Remember, these patients should be re-anticoagulated as soon as it's safe to do so. 30-day mortality was 24%. Interestingly, only 2/3 of the patients would have actually gotten into the Vexinet study. So real-world experience with this drug is limited, but is actually looking very positive. A high fraction of patients have a return of normal hemostasis. So where are we in 2021 with respect to reversal agents? So first of all, remember that the best way to treat a bleed is to not have it in the first place. So when you have a patient who is being considered for antithrombotic therapy, always use rational thrombotic therapy, antithrombotic therapy. Always review current guidelines and make sure your work is in compliance with guidelines. Most patients with DOAC-associated bleeding require only generic supportive management. For life-threatening bleeding in a patient who does or is likely to have important amounts of dabigatran on board, idarucizumab should be used if you have available. If you do not have it available, then you could use activated prothrombin complex concentrate, and the decision-making can be aided by the PTT or thrombin time. For life-threatening bleeding in a patient who does or is likely to have important amounts of 10A inhibitor on board, consider Vexinet if it's available, and if it's not available, consider the use of PCCs. Decisions about the use of very expensive reversal drugs, including idarucizumab and PCC, would be greatly aided by point-of-care testing that is inexpensive, reliable, fast, and truly point-of-care. These tests do not exist in North America, but there is a urine dipstick for DOACs that has become available in Europe that I think actually has a great deal of utility here, and it would be interesting to see whether or not it could achieve approval in Saudi Arabia. Thank you for your attention. I'd like to thank the organizers for inviting me to